Good evening, everyone present here. Today's topic is infectious and immune disease. And the speaker that we have here is Dr. Suvadeep Sen, sir. He is a consultant ICU in Apollo Hospital, Navi Mumbai. So you may start. Thank you.
Thank you. Thank you, Fatma, no? Sorry.
Yes, sir.
Yeah, thank you, Fatma. Good evening, everybody. I can see 11 participants joined over there. So today we are going to discuss a few MCQs. Sorry. So we'll discuss few MCQs that comes or that may come as a on infection and the immune disease aspect in for EDIC Part 1 examination. We'll be discussing few MCQs which are relevant to this topic. Now in EDIC Part 1, as it is an European diploma, so most of the time that the common diseases or common tropical or other infection diseases that we see over India or subtropical countries, that may not come in EDIC Part 1. So their questions are a little unique. So we'll try to discuss few of the questions so that you get an idea that what kind of questions you may expect in European kinds of examinations. Okay, shall we start?
Yes, sir, we can.
Okay, then I'm just asking few of the participants. So again, all participants, I'm just requesting you to unmute yourself and be a little interactive so that I can interact with you, or you can give your answers to the chat box. Because this kind of MCQs, you may become right, you may become wrong, but unless you interact, I'll not be able to assess the what kind of things we are heading. Okay, starting with the first questions. So everybody is able to see the question over here. Participants, can you see the question? Hello, doctor. Some of you, please unmute yourself and then give an answer.
Yes, sir, we can see.
Okay. Okay. So as I have told you that usually will not be able to, you will not see you will not see the questions which are very typical that we see often in our day-to-day practice. So mostly EDIC Part 1 is more theoretical. So you will expect a lot of questions on which are theory based. There are very few clinical questions also you can expect in EDIC Part 1. There are few image based questions also you may expect in EDIC 1. But again, you need to know the theory part of it is very well. Okay, the question number 1. A 58-year-old man with a septic shock secondary to intra-abdominal infection has been in the ICU for 12 days despite broad-spectrum antibiotic. He now has persistent fever, lymphopenia, skin allergy tests, and developing nosocomial pneumonia. Monocyte HLA-DR expression is markedly reduced. Now, what is the question? Question is, which of the following best describes the patient's current immunological state of the patient? A. Cytokine storm with persistent pro-inflammatory response, restoration of hemostatic immune balance, sepsis-induced immune paralysis with immune exhaustion, primary humoral immunodeficiency, graft versus host disease-like reaction. So I will request you either unmute yourself and give me the answer, or you can put your answer in the chat box so that I can see it and then I can assess and then we can proceed. Anybody? I'll give you just some time. I'll keep my chat box open so that I can come to know whether you're giving some answers or not. Okay, Dr. Saifon. All of you are from, just to being a little inquisitive, so you are all from which part of the world, if I may know? You're all from India or some of you outside India as well? Dr. Saifan C, Dr. Ankita C, Dr. Lux, Dr. Nidhi, Dr. Yes, so I've just given answer because lot of, yeah. Okay, 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 okay. Okay, we've got a kind of good answers over here. So all of you, most of you have given the right answer over here. So this is a state of immune paralysis. So I will discuss a little bit of theory about it because everybody should know that what is sepsis-induced immune paralysis and all, and why it is the right answer, why it is not the other answers are not correct. So we'll just briefly discuss these things. We'll try to answer a lot of MCQs over here. So if you see that the sepsis pathophysiology, mostly in the early phase of the sepsis, there is a cytokine storm. There is a lot of SARS response that happens. So it's mostly a pro-inflammatory state. Now, in the initial phase of sepsis is mostly pro-inflammatory. Now, most of the patients they tied up with the part of the sepsis, they get treated, and then they gradually recover. But there are few patients, if you go in the pathophysiology of the sepsis, then they might develop a persistent state of inflammation. That is called persistent inflammation and catabolism syndrome. That is called PICS. So this is a kind of very dreadful situations of patients with who undergo sepsis, who keeps on developing a lot of secondary complications due to sepsis. So these are the four spectrums of this persistent inflammation. Number one is chronic critical illness, where they have a persistent organ dysfunction. There are certain patients who develop persistent inflammation, so the persistent cytokine storm and the multi-organ dysfunction state persists. There is a sepsis-induced immune suppression that happens in few patients after acute hyperimmune phase, who are characterized with lymphopenia and nosocomial infections. And there are few patients who develop PICS, like persistent inflammation and catabolism syndrome, which is one of the leading cause of disabilities in this kind of patients. So this later phase of the sepsis is extremely disabling to a lot of patients. So we should know about all these four spectrum of persistent state of inflammation and the catabolism and the immunosuppression, because these are kind of very high risk. These kind of patients are very high risk of mortality and morbidity. So in the questions that we have described, that the patient is persistently in the abdomen, persistently infected septic for more than almost 2 weeks, and he has developed nosocomial inflammation. So usually we suspect in this kind of patients, we suspect some amount of immunosuppressed state, and it has been told that he has some lymphopenia and skin allergy, and the HLA-DR4 expression is reduced. So they're the hallmark of immunosuppressed state. So what happens in this phase? There is a lymphocyte dysfunction happens, and there is an anti-inflammatory cytokines like IL-10 and this TGF-beta. They get stimulated over here. So all these things cause an immunosuppressed state in terms of monocyte deactivation and impaired phagocytosis, and they are very prone to develop secondary infections. How do we diagnose this persistent immunoparalysis state? Usually we see lymphopenia. So we see a loss of CD4 and CD8 cell count over here, so which decrease the adaptive immunity response. And there are certain T cell exhaustion, which is a kind of hallmark of this state. And there is a state called compensatory anti-inflammatory response syndrome, or CARS. We have all known the systemic inflammatory response syndrome, but compensatory anti-inflammatory response syndrome is one of the major cause of mortality in patients with the sepsis. If they remain up persistently in the ICU, they develop secondary infections, keep on developing some other complications, and they develop immunoparalysis, state of immunoparalysis. So this is one situation everybody should be aware of, and this is one of the area that there are a lot of researches are going on, and they are very favorite to the examiners as well, especially for the theory examinations. Everybody should know about this syndrome exist. Everybody understood this state, the compensatory anti-inflammatory response. You should know about this state. Okay. So coming to, these are theories going on. Coming to the second question. Again, question number two, a 35-year-old woman with a history of recurrent meningococcal infection is admitted with uh, admitted with septic shock. She has normal neutrophil count and immunoglobulin level. Complement testing shows low complement level, low C3 and normal C4. Now, which component of the complement pathway is most likely deficient in this patient? Again, very, very theoretical questions, but again, very, very clinical important questions as well, because most of the time complement deficiency is one of the major cause of having recurrent infections, and it's a state of immunocompromised status. And this anybody who has a complement deficiency in the body, they are very much prone to develop secondary infections or recurrent infections in the body. So, which component of the complement pathway is most likely deficient in this patient? Any answers? Can you check in the chat box whether Dr. Lakshmi Narayan? Answer is B, C2. Okay. Any other answers? Again, complement pathway is one of the favorite questions of lot of examiners, and especially the EDIC part 1 examinations. You should expect a lot of questions on this kind of uh, immunological disorders in the body. So you should always be prepared of. Tankita A, Dr. Reed A. So we'll see that what is the answers over here. We have given 30 seconds now. So we have got some answers. The answers over is factor B. So answer is C. So again, explanation normal C4 and the low C3 with low. So what is CH50? CH50 is a test for overall complement function status inside the body. So low CH50 means that the overall complement function in the body is low. And now once the complement function is low, then after that we check for the individual complement factors. Like here we have found that the patient has a low C3 and the normal C4. So low C3 and the normal C4 usually suggest an alternative pathway defect. So factor B is essential. We need to, so again, this is a very rigorous chart, but again, very important for the theoretical part of the EDIC part 1 kind of exam. So everybody should know that the complement pathway defect and how do we suspect the complement pathway defect in regular day-to-day clinical practice. Like suppose somebody in a classical pathway defect, they are usually defected in the complement C2 and the C4 deficiency, and they are very prone to develop infections with the hello. Okay. Right. So they are usually very prone to develop infections with the encapsulated bacteria like Streptococcus pneumoniae, Haemophilus influenzae, and they are also prone to develop various autoimmune diseases like SLE. So classical pathway defect, they make them prone to develop autoimmune diseases and then the infections with the encapsulated bacteria like Strep pneumoniae and the Haemophilus influenzae. Second component is the C3. And C3 is a migration center of both classical and the alternate pathway. So C3 deficiency usually they develop recurrent infection with the encapsulated bacteria like Pneumococcus, Neisseria, and the Haemophilus influenzae. There are very this kind of patients usually they come very sick and there are usually life-threatening infections they usually come with because C3 is an integral component of both the pathways. Alternative pathway is usually they usually develop multiple meningococcal infections or infections in the especially in the early adulthood or early childhood. They develop meningeal infections or meningococcal meningitis in these patients. If somebody comes with the multiple meningococcal infections, usually we suspect the alternative pathway defect. So they are the factor B or factor D deficiency. And suppose somebody comes with a recurrent Neisseria infections, then the terminal pathway or C5 to C9 defect we usually suspect. And sometimes another entity like somebody comes with a hereditary angioedema, we suspect C1 esterase inhibitor deficiency. Again, there is one life-threatening complications that is associated with a complement factor deficiency. So again, for EDIC part one is more theoretical, so you should know this complement pathway and their associated diseases. So be thorough with this kind of diseases and then expect some questions on this topic. Now, what are the clinical clues that suggest complement deficiency in day-to-day clinical practice? Suppose somebody develops recurrent meningococcal infections, we think of terminal pathways. Somebody with a recurrent sinopulmonary infections, we usually, or early onset SLE, this suggests a classical pathway defect. Some invasive infection with encapsulated organisms, we suspect the central component of C3 deficiency. And some family history, if they are or X-linked pattern is there, then it suggests the property deficiency. Again, more theoretical part, everybody should know about this complement pathway defect. Going to question number 3, is that okay? Now again, one more immunological disorders and with the infections. A 62-year-old man with a metastatic melanoma on anti-PD-1 antibody therapy presents with rapidly worsening dyspnea, hypoxia, and diffuse bilateral infiltrates. Is intubated, started on broad-spectrum antibiotic, bulk cultures are negative. BAL is lymphocytic predominant. Now, what is the most appropriate next step? Again, anti-PD-1 therapy, again, everybody should know that these are the kind of new therapies, molecular therapies that has come as a treatment options for advanced malignancies. So a lot of patients we see in patients coming to the ICU after having complications of these kind of therapies. So we should be aware of what are the life-threatening situations that can happen in patients who are on monoclonal antibody therapies after in metastatic malignancies or advanced malignancies. Like again, these patients is on nivolumab, which is anti-PD-1 antibody. Again, you should know this kind of terms so that you don't get surprised in the exams. And these are very common medicines. They are prescribed nowadays in advanced malignancies. Now, what are the next appropriate step in these kind of patients? These patients continue antibiotic and add antifungals, high dose corticosteroid for suspected immune related pneumonitis, IVIG for hypogammaglobulinemia. We should perform the transbronchial biopsy to rule out malignancy and start anti TNF alpha. Anybody? Any answers? I think these are the answers that they have given for the. Any guess? Anybody? Dr. Nidhi A. Okay. Anybody has encountered this kind of patients in their ICU or any experience? Again, I've kept these kind of questions. First of all, I know matlab, this might be a little difficult for all of you, but again, this is the kind of questions that there's the kind of things that we are seeing in the ICUs more and more at this moment of time. And all these European examinations, they do not give a classical questions on the TB, tuberculosis, and all these things, which we see in India at least more and more as a infections. They usually give more immunological questions. Now, again, to make these questions a little, so these are things everybody should know. So what is the answer over here? The answer here is that we need to give us high dose corticosteroid in this kind of patients. Anybody who has received anti-PD-1 antibody therapy or treatment with monoclonal antibody in advanced malignancy, they develop a lot of immune-related side effects. Like they might develop immune-mediated pneumonitis, they might develop immune-mediated colitis. So again, suppose the same patients they come with loose motion, extreme loose motion, then we suspect immune-mediated colitis. Treatment for all these immune checkpoint inhibitors, they're called immune checkpoint inhibitors. They called immune-mediated pneumonitis or immune-mediated colitis or immune-mediated other problems. The treatment is hydrosteroid. So All patients, any patients who received immune checkpoint inhibitors, we should know the side effect. One of the major side effects of all immune checkpoint inhibitors are uh, is the immune mediated complications. The treatment for that thing is high dose steroid. Now, again, the questions is very specifically told you that here the ball is lymphocytic predominant. That means that it is more immunological problem. Had the ball told, had the questions given you the option that the ball has grown some filamentous fungus or some suggested some amount of infections, probably the antifungal would have been right answers. Here we do not suspect hypogammaglobulinemia over here because there are no hypogammaglobulinemia is a condition of immunodeficiency. There is no evidence of immunodeficiency in the question, so we do not suspect over here. So IgG is not an option over here. Malignancy, these patients are already malignancy, so they have been told. So we do not do a transbronchial biopsy. So again, if we do not know the answers rightly, they have pointed out to the diagnosis like BAL is more lymphocytic predominant, the culture is negative. So the answers over here is corticosteroid. Just 1 minute. Here is one. Okay. Okay, understood. Anybody? Any answers? Any doubt? Nobody is interacting. Okay. So we'll proceed. Let's proceed. Question number 4. A 58-year-old man with a newly diagnosed glioblastoma multiforme is receiving temozolomide. Again, one of the advanced chemotherapeutic agent. I do not know how many of you have heard about this medicine. But this is again one of the chemotherapeutic agents that are very routinely used in patients with a glioblastoma multiforme, and we have seen a lot of patients in our ICUs as well, and this is the kind of very routine things that is there. So this patient is receiving temozolomide and radiotherapy. He presents with progressive dyspnea, non-productive cough, low-grade fever, oxygen saturation is 89% on room air. CT chest shows bilateral ground glass opacities. His WBC count is normal, but lymphocyte count is low. He is not on any antimicrobial prophylaxis. Which of the following is the most likely diagnosis over here? Any answer? See the chat box. Anyone want to try guess? Dr. Reed, so he says about radiation pneumonitis. Okay. Dr. Siphons talks about radiation pneumonitis. Okay. Dr. Dinesh talks about pneumonitis, zero pneumonia. Okay. Anybody? Again, you will not be deducted of marks over here, so we can answers. And in EDIC Part 1 examinations, everybody should give answer to all questions. So I don't think there is any negative marks in EDIC Part 1 examinations. So you should always try and answer all the questions in EDIC Part 1. Okay. 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 So anybody has heard the name of this medicine, temozolomide? Anybody? Anybody has uh, encountered any patients who has received temozolomide and comes with this kind of problem? To be very frank, Malab, it is one of the very common side effect of temozolomide. And why I have very intentionally kept these questions because it's one of the very common side effect of temozolomide. And most of the time, if you before starting this temozolomide, oncologist always talks about this side effect, and this is one of the very dreadful side effect of temozolomide. Everybody should know about this. Again, okay, Dr. Ankita, no, nobody else. Okay, I don't know whether I have. Okay, we see a lot of patients with temozolomide induced this kind of problem. The answer over is pneumocystis pneumoniae infections. Now, anybody who is receiving temozolomide, it is mandatory to keep them on PCP prophylaxis. Why? Because the PCP or pneumocystis cerevisiae infections is a very common side effect of temozolomide. So it is a mandate to give septron prophylaxis or co-trimoxazole prophylaxis in these kind of patients. So again, what I'm saying that we should know these kind of things more and more because they are being used more and more over here. They're not classic questions. Usually, you do not expect a lot of classic questions in EDIC Part 1 examinations. But yes, temozolomide, it's very commonly used chemotherapeutic agents especially in the glioblastoma multiforme. And if some patients on the temozolomide is not on septum prophylaxis and comes this kind of problem, it's a very typical description of PCP pneumonia. The progressive dyspnea, non-productive cough, low-grade fever, desaturation, hypoxia, with a bilateral ground glass opacity. It's a very classical description of pneumocystis carinii infection or pneumocystis cerevisiae infection. And then again given a hint over here, he's not on any antimicrobial prophylaxis. So the answer over here is PCP pneumonia. So and usually these kind of patients should receive PCP prophylaxis, and now he has developed PCP infection, so he should be treated with steroid and chlorotrimmoxazole. Okay, anybody has any question? Okay, should we proceed? Are they difficult? Okay. Okay, difficult. So again, it might sound very difficult if you do not know it. Now you know this question. So next time, whenever you see any patients with a temozolomide, or you see a MCQ with temozolomide, you know that the answer is pneumocystis carinii or pneumocystis cerevisiae pneumonia, because there is no other answers to it. And usually the question typically comes on this particular topic only. Like suppose somebody on immune checkpoint inhibitor therapy, you will always expect either in form of immune mediated pneumonitis or immune mediated colitis. So you just need to know the question. Once you know the questions, the next time you remember most of the time. Especially it is really important to know in the clinical practice, day-to-day clinical practice. Somebody comes to the temozolomide with this kind of fracture, you do not treat or give an empirical treatment of chlorotrimmoxazole or steroid. That means you are almost on the verge of losing the patient. So you should know. Okay, coming to question number 5. Again, 29-year-old male presents with a fever, cytopenia, pancytopenia basically, hyperferritinemia, splenomegaly, mild liver dysfunction, bone marrow biopsy shows hemophagocytosis. So you know the diagnosis mostly. Infection screen is negative, IL-2 receptor is elevated. What is the most underlying immunological mechanism of this condition? So what is the condition over here? Anybody? What is the condition that has been described over here with this clinical picture? Anyone? Which conditions we are talking about? HLH, very good. So now the question is not on HLH, they were diagnosed. You diagnosed HLH. Now, so what is the underlying immunological mechanism of HLH? Yes, it is hemophagocytosis. It is HLH. Very good, doctor. Uh, what is the what is the immunological mechanism of hemophagocytosis? What happens over here? So what is the answer over here? Whether it is a defective T cell function or whether it's a hypersecretion of interleukin 1 and interferon gamma from cytotoxic T cells and the macrophage, or whether complement mediated microvascular thrombosis, or whether B cell hyperactivation and immunocomplex deposition, or it's a mast cell degranulation. Questions on immunological diseases are a little difficult, probably, if you do not know the answers to it. So, so but once you know the answers, it is easy, and they're usually high scoring in EDIC part one, because sometimes that might distinguish whether you clear or not. Because almost 60 to 70% of questions in EDIC part one, most of the candidates will be able to crack it, but there are 30-40% of questions sometimes they will be giving a little tricky. So these are the areas they are very high scoring. So if you know, you will be able to give answers, and that will distinguish you whether you will clear or not. Okay. So what happens over here? It is what is the answer? So it is a answer is B. So as the term is hemophagocytic lymphohistiocytosis, so it's a hyperinflammatory condition with cytokine release syndrome. So it involves interferon gamma and the interleukin 1, and it involves the macrophage. It's a problem of macrophage. So that is the basic problem of hemophagocytosis or HLH. So as I can see, the most of you have given the right answer over here. So good that we have given the right answer. So even if you do not know the right answers over here, so it's a problem of macrophage. So always you should know that the HLH is a problem of macrophage. So it's not a defective T cell function. What happens in the it's not a microvascular thrombosis which happens in complementary medical problem. So HLH diagnostic criteria. How do we diagnose? First of all, we need to understand this is a problem we are dealing with HLH, because this patient has fever, splenomegaly, hyperferritinemia, increased soluble CD25, hemophagocytosis. So everything has been given over here. So this is the diagnostic criteria of HLH. So you see all these criteria, and then you see to you first of all understand this is a case of HLH, and then you go to the next phase, what is the molecular or immunological mechanism. Question number 6. A 45-year-old male with acute myeloid leukemia underwent allogeneic stem cell transplantation 4 weeks ago. He now presents with diarrhea, rash, elevated liver enzymes. Skin biopsy confirms apoptotic keratinocytes with lymphocytic infiltrates. Question: which immune cell type is primarily responsible for this process? Number 1, host B cell attacking donor graft, donor CD8 cells attacking host tissue, host NK cells rejecting engraftment, donor neutrophil causing type 3 hypersensitivity, or donor macrophage activating complement. Again, very confusing you might feel, but first of all, again, we need to diagnose what is the condition we are talking about. Okay, somebody has responded as D. So first of all, what condition we are talking about over here? Anybody? You can either type or you can unmute yourself and then tell. Yes, GVHD. It's a graft versus host disease. Again, it's very commonly seen in the ICU. Why? Because uh, we see a lot of bone marrow transplant happening over here, and then uh, graft versus host disease is one of the quite common complications or known complications in patients with allogeneic stem cell transplantations. Everybody should know about graft versus host disease. How do we diagnose it, and how do we treat it? So clinical presentations is again typical of graft versus host disease, like somebody who underwent a allogeneic stem cell transplantation 4 to 6 weeks ago, comes with rash, diarrhea, and elevated liver enzymes. That means you are talking about graft versus host disease. It's an acute graft versus host disease. So what happens in the graft versus host disease? It's a donor cell that attacks the host tissue. That is the basic pathophysiology of graft versus host disease. Unlike rejection, in rejections, it is a recipient cell that attacks the donor tissue. That is how the rejection. That is the basic pathophysiology of rejection. But in graft versus host disease, it's the donor cells that attacks the host tissue. That is the basic difference between the rejection and the graft versus host disease. So in GVHD, graft versus host in GVHD, the donor T cells, especially cytotoxic CD8 cells, they recognize recipient tissues as foreign and it causes a cytotoxic cell damage to all around. It's a systemic complications. How do, again, we need to know that the diagnostic criteria of graft versus host disease. Again, we don't need to remember all these criteria, but it is good to know things, especially acute GVHD, this magic criteria with a typical skin manifestation, liver manifestation, and the GI manifestations. They're very typical. Anybody with a bone marrow transplantation happened within 4 to 6 weeks comes with a rash, elevated liver enzymes, and diarrhea or loose motion. That means, and skin manifestations, especially, it's very typical of skin manifestation. That means we are talking about GVHD, acute GVHD. And basic pathophysiology, again, we need to remember, it's a basic pathophysiology is it's a donor cell that attacks the recipient cells, unlike the rejection. It's a donor cells which attacks the recipient cells and causes systemic problem. Okay, let's proceed. It's a okay, yeah, GVHD diagnostic checklist, acute GVHD and a chronic GVHD. There are a lot of differential diagnosis. Before diagnosis of GVHD, we should always rule out infections like viral. A lot of viral, especially rickettsial infection, they mimic GVHD. CMV is one disease that we should always rule out before diagnosis of graft versus host disease, because CMV very closely mimics GVHD. So we should always rule out CMV infections over here. Drug reactions, disease relapse, or and the post-transplant autoimmune disorders, they sometimes mimic GVHD. So we should rule out all those things. Biopsy is a confirmatory in the GVHD. So we should do a skin biopsy and should diagnose GVHD with the skin biopsy. Okay. So again, let's proceed. Question. Recipient tacrolimus, mycophenolate, and steroid presents with subacute confusion and fever. CSF shows lymphocytic pleocytosis, elevated protein, and low glucose. Indian instant is positive. Which one is the most likely causative organism? I think everybody should be able to give answers to this question. I want everybody to give right answer. Okay. B, B, B. Anybody apart from B? Any other thought process apart from B? But again, yes. So as expected, everybody is right. So the answer is Cryptococcus. Again, it has been very evident with these questions that they have told that Indian ink stain positive. So they just need to know whether you know that the what is this India ink stain for. Otherwise, if you know that the Indian ink stain is for Cryptococcus, that means you crack this MCQ. So that is how the previous questions are also. So you know that the right part, you know the answer. So that is like it. So I don't think there is anything we need to discuss about this question further. So it's undoubtedly it is a cryptococcus neoformans, cryptococcal meningitis. We're talking about cryptococcal meningitis. Okay, going to the next question. In a patient suspected with hemophagocytic lymphohistiocytosis or HLH, which of the following is the most specific of diagnosis? We spoke about it again a while ago. So again, I want all of you to give a right answer over here. So please cast your answer over here. Anybody? Dr. Lux Manarajan. Dr. Lux Manarajan is E. Dr. Saifan is E. Okay. Anybody wants to differ or anybody wants to go with E? Dr. Ankita is E. Good, good, good. I'm happy that all of you are theoretically very sound. I can see it. So yes, the correct answer is over here is E. So this soluble IL-2 receptor, so the soluble CD25 is the pathognomic or very specific of HLH. If you need to diagnose HLH, you need to send a soluble CD25 testing. And if the soluble CD25 is elevated, that means your diagnosis is right. So all the other things they are supportive, like raised triglyceride, raised NK cell activity. We do not do over here the NK cell activity assay. I do not know whether it happens or not in any part of the world, but we do not do it. Cytopenia, raised ferritin, they're all non-specific tests, but elevated soluble CD25 tests, soluble 25, it's the hallmark of HLH. So again, you know it, you know the answer, you will be able to correct it. Okay. Again, I think we have already done it. Okay, let's see. So 67-year-old man with metastatic melanoma develops pneumonitis after receiving PD-1 inhibitor. So we have already done one question on nivolumab, like this is called immune checkpoint inhibitor. He's being treated with steroid and improves. 3 weeks later, he develops fever, productive cough, bilateral infiltrates, bronchial left shows filamentous, weakly acid fast branching organisms. Now, which one is the most likely diagnosis? Okay, so this is not the last question. So that means the bronchoalveolar lavage is not the last question. The bronchoalveolar lavage was lymphocytic. There is no organism. Here we found here we find a filamentous weakly acid fast branching organism. So which one is the right answer? Okay, let me see that who has given answer. So Dr. Dr. Siphon is C, Dr. Reed is C, Dr. Ankita is B, Dr. Siphon. I think that is the right. Okay, C, C, C. Okay, good, good. I think again you are right. All of you are right over here. So the answer over is nocardiosis. So again, you need to know that the crux over here and the crux of the question over here is that so we get a weakly acid fast positive organism and which is filamentous. So we know that the what test is there and then we know the answer. So nocardia is again we should know that it's a so again we got a immune checkpoint inhibitor. We did a BAL. It's very important. We did a do a BAL on these kind of patients. Here the bronchial lavage testing is more pointing towards infection. So here we found out on infections. The infection over here, they have told it's a acid fast bacilli, acid fast organism, branching organism. So it is nocardia. So the patient is immunosuppressed. So that is one of the opportunistic infection we should all be worried about in these kind of patients. Okay. So its characteristics. So again, in EDIC, they will give hint to the correct answer. So we need to just pick it up and then give a right answer. Okay, now it is being more easier, isn't it? Yes, I hope so. Question number 10, 60-year-old liver transplant recipient, 8-month post-transplant presents with confusion, fever, mild neck rigidity, has been on tacrolimus, low dose prednisolone, MRI brain. What does MRI brain show? So, anybody? C, D, good, good, good. What does MRI brain show? So, MRI brain show over here the multiple ring enhancing lesion. So among all these things, whichever has been given over as a differential, they can all cause meningitis. But here they have particularly told that we have a multiple ring enhancing lesion, which can cause multiple ring enhancing lesion. Only toxoplasma can cause. So there's only DD over here, amongst all other options, which can cause ring enhancing lesions. Very good. I'm very happy that you are all reading. You are theoretically quite sound. So the answer over here is toxoplasma. So we should know what are the degrees of ring-enhancing lesion in the MRI brain. I'm not going into details, just it's a more theoretical part. So just know and remember, and then you should be able to crack. Question number 11. Again, it's very important, and everybody should know about this thing. So which of the following transplant recipient donor CMV serostatus combination confers highest risk of primary CMV disease in post-transplant? Donor CMV minus, recipient CMV. So it's called D minus, R minus, or D plus, R plus, D minus, R plus, D plus, yeah, R minus, D minus, recipient unknown. So which one is the highest? Let's see. Somebody has already started giving answers. So Dr. Sanat Kumar has given answers B. Dr. Nidhi Agarwal has given D. So anybody who has done it before probably will be able to give answers. Dr. Reed is D. Dr. Saifan is D. Very good, very good, very good, very good, very good. Dr. Lux Manarajan is C. Okay, okay. Please let me know whenever we are passing through the MCQ, it's not about one single MCQ. Suppose if you have any doubt of the other options which I am stating as a right option, let me know. Somebody wants to speak. No. Okay, so you can hear. I'm seeing a lot of echoes. Okay, so answer over here is D. So as rightly stated, like a lot of people have given a correct answer. I'm very happy about it. Like anybody, again, everybody should know about these things because our understanding about the disease are evolving. So whenever we are working as an intensive care specialist, it's not only management of common things. We are seeing a lot of critical things, a lot of advanced things. Like transplant is one of the things that are being happened in a lot of centers. So we should know about this kind of disease. Like anybody who has a D, it's called DR and R minus. That means that the donor CMV positive, the recipient CMV is negative. That means that there's a highest risk of transmission from the donor to the recipient. So this kind of patients should always receive CMV prophylaxis. CMV prophylaxis, especially for the liver transplant recipients, they are not the rule. But anybody who has a donor CMV positive and the recipient CMV negative, they have to be provided on the CMV prophylaxis. So because they're at highest risk of transmission, it's called donor-derived CMV infections. So highest risk CMV risk is when the CMV seronegative recipient receives organ from seropositive donors. It's called D plus R minus status. If it's a D plus R minus status, you have to give CMV prophylaxis. Otherwise, these patients will develop CMV disease within 1 or 2 weeks of time, and then CMV disease in post-transplant scenario, they are always life-threatening. Okay, good that most of you have given the right answer. So again, this is kind of more theory part. So universal prophylaxis is the rule for D plus R minus. And even for D minus R minus also we give a prophylaxis because especially if they have received any point of time recipient is CMV negative, we tend to give CMV prophylaxis because they especially if they receive blood or blood product transfusion because they can get CMV from the blood and blood product transfusions as well. Okay, question number 12. A 52-year-old renal recipient presents with a rising serum creatinine. Urine cytology shows decoy cells. Plasma PCR shows BK viremia. Anybody has heard the name of BK virus? Again, one very important thing everybody should know. One very important infection disease everybody should know, especially in the post-transplant setting. So BK virus infection. It's very important, especially post-renal transplant. It is PK virus infections is one of the leading cause of graft dysfunction in the post-transplant setting, apart from the rejection. So, what is the most appropriate step. Is the graft dysfunction is because of this BK virus over here, or it is because of this rejection? That is the crux over here. So what do we need to do? We need to give valganciclovir or begin a high dose steroid, or we need to reduce immunosuppression, or we need to perform the transplant nephrectomy, or we need to add cyclosporin to this regimen. So what is this disease about? Let's see what the answers have been told. New BK virus, Dr. Saiful. No, okay, you have not heard about BK virus infections. Okay, please. So again, BK virus infection, again, should know about it, especially post kidney transplant, especially if your center is doing a kidney transplant more and more, or if you get a post transplant patients coming back to the ICU, then for all kidney transplant patients, the BK virus infection is one of the deadliest, or one of the common things that is a cause of graft dysfunction. Now, first thing, what we need to understand whether this graft is. So here the patient has come with some amount of graft dysfunction. We should know whether the graft dysfunction is because of this BK viremia or it is something else. So again, they have given a very promising hint over here. So the urine cytology has shown decoy cells. Decoy cells is a very characteristic feature of BK virus infection inside the kidney. Not all BK viremia lead to BK virus related associated nephropathy. But if you find the decoy cells in the urine, that means it is they are hinting towards a BK virus associated nephropathy. It's called BKVN. So here, what is the treatment? Treatment is BK virus associated nephropathy is to reduce immunosuppression. If you do not reduce immunosuppressions, this graft will be eaten up by the BK virus and you will end up losing the graft altogether. So you should know again, you know the right answers by knowing that it is a BK virus associated nephropathy, that you know the answers over here. So one more questions about this topic. Which of the following diagnostic finding is most specific for BK virus associated nephropathy in a kidney transplant recipient? Positive urine decoy cells. We have already spoke about it. We already spoke about it. Elevated serum creatinine. Okay, it hints towards the BK viremia. It hints towards the BK virus associated nephropathy. Positive plasma BK viral load more than 10,000 copies per ml. Positive SD40T antigen staining on the renal biopsy. BK viruria in absence of viremia. So, what is the most specific test? Again, we why I have kept two questions on BK virus infections over here, because this is one infections again everybody should be aware of. This is a little uncommon. We do not read about it a lot, but again, if you do not know about it, you might lose patient. It's clinically important.
చూడు పిలుస్తున్నాడు షేరు వినపడట్లేదు.
Hello. Okay. If you're not talking about this particular, please, doctor, please mute yourself. The correct answer is D. So viremia, the explanation has been given over here. Viremia and the viruria suggest BK infections, but the definitive diagnosis requires a biopsy. So all BK virus associated infections, they are diagnosed in the kidney biopsy. So like any patients who comes with a graft dysfunction, you should usually the biopsy is the norm. You do a biopsy and the biopsy you do a specific staining. This kind of specific staining is very much specific for BK virus associated nephropathy. It's called BKVAN. So it is a this kind of this staining tells you that the viral replication inside the tubular cells or grafted kidney. So that is why it is very very specific in the for the BK virus associated nephropathy. We talk about a little bit more about the BK virus associated nephropathy. So usually BK virus again stays dormant. It's like a CMV, it remains dormant. Reactivation occurs under intense immunosuppression, especially after kidney transplant. It's common after kidney transplant. It's not very well known after other transplant. Uh, Important to note is that not all patients with a BK viral load more than 1,000 or 10,000, they can cause BK virus associated nephropathy. Usually it happens after 1 to 3 months after the post-transplant, but it can happen anytime after within a year or more than a year. Risk factors: high dose immunosuppressants, especially somebody who has received ATG or lymphocyte depleting therapies or basiliximab or previous rejection. Suppose somebody has a CMV co-infection. So those kind of patients, they are prone to develop BK virus-associated nephropathy. Red flag that raises up. So anybody who develops unexplained graft allograft dysfunction, we suspect BK virus infection post kidney transplant. Usually we see for the first we do a plasma BK viral load, and we see for the urine for the routine testing and the decoy cells. If the viral load is more than 10,000, then we do a kidney biopsy and confirm the diagnosis. That is the diagnostic algorithm that is followed for the BK virus associated infections. So just need to remember this much. We'll be able to answer all questions that comes associated with these kind of questions in EDIC part 2 at least. EDIC part 1 at least. Okay. How do management? Always BK virus associated infection. The management, crux of the management, you should reduce the immunosuppressants, especially mycophenolate antimetabolites. We should reduce as much as possible because they make them prone to develop BK virus associated nephropathy. Usually there is no antiviral therapy. People have tried cidofovir and leflunomide, but most of the time we end up not giving an antiviral. Antivirals usually do not work. We just reduce the immunosuppressants and then they come out of the graft dysfunctions. Okay, should we proceed, or it is almost 1 hour? Should we proceed or should halt? Fatma ji, should we proceed or should we halt? This is already 1 hour. I think
So if you are willing to proceed, it's fine. If we can also wrap up the class. We can schedule a class 2 too.
Okay, so what does the candidate want?
All the aspirants, please let us know. Shall we resume the classes? Class, this one?
I think we can discuss, I think, another 10, 12 questions over the next 1 hour.
Sure, sir. Sir, you can take more 1-2 questions, then we'll wrap up.
Please let me know, Dada. Okay, doc. Few people are told to proceed, but I have almost another 15, 20 questions might be there. So I don't think I'll be able to finish it today, but okay, we'll carry on. Fatima ji, please let me know if I need to stop at any point of time. I can arrange one more class on the same topic.
We'll wrap up.
Okay. So we'll do up to 15 and then we'll stop. Is that okay?
Yes, sir.
Okay. Question number 40. 52-year-old farmer is admitted with fever, confusion, and hypotension. Okay. Examination reveals an issue on his abdomen and the mild hepatomegaly. Lab findings shows thrombocytopenia, elevated transaminases, and mild ARDS. What is the most likely pathophysiological mechanism leading to his shock? Okay. So I hope everybody has been able to diagnose over here. What is the diagnosis in this patient? Let's see. What is the diagnosis? Anybody? Everybody should be able to diagnose this case. Unless we diagnose, then we will not be able to go to the next phase because the question is not on diagnosis. It is about the pathophysiological mechanism of the diagnosis. Good. Okay, rickettsia, it's good. Scrub typhus, good. So it's a scrub typhus. Whenever we talk about this kind of issue, so this scrub typhus is one form of rickettsial infection. It's true. So it's a systemic scrub typhus infection. It's a scrub typhus. What is the underlying pathophysiological mechanism of the scrub typhus? So what is the answer, doctor? So we have diagnosed the scrub typhus infection over here. So what is the basic pathophysiological mechanism on the scrub typhus? Endotoxin related damage, vasculitis related damage, direct cardiotoxicity, immune mediated damage, adrenal insufficiency. What is the thing that is a basic pathophysiology of scrub typhus? B, very good.
Okay.
Can you please mute? Where is there? Yes. So yes, so I think again everybody is right over here. In scrub typhus, we should always remember it is a pathophysiological mechanism is vasculitis. Again, as I'm telling, EDIC part 1 is more theory based, so you might expect this kind of question. And the basic idea to keep all these questions in the over here is to make you aware of this kind of questions might come in your exam, so that you read about it. So again, you're right over here that it's a vasculitis kind of thing, scrub typhus or rickettsial diseases. They they cause vasculitis kind of pattern of injuries inside the bodies. So they cause endothelial dysfunction in the capillary leak. So that is how they develop capillary leak syndrome, the ARDS, hypotension, and a multi-organ dysfunction state. So again, good that you have given the right answer. So again, to give the right answer, first of all, you need to diagnose this condition and then you can give answer. Okay, so vasculitis is the right answer. Question number 15, I think that is the last question that we'll do today. Again, so which one of the most following is the most sensitive early diagnostic test for scrub typhus in the ICU setting? Well Felix agglutination testing, IgG, ELISA, IgM, IFA, real-time PCR, blood culture. Let's see what people have. Please give answer. Feel free to give answer. Dr. Dinesh has talked about D. Can I expect 2 or 3 more answers from everybody? Dr. Laxmananjan talks about C. Okay. Dr. Saifan talks about C. Okay. Anything. Everybody in EDIC, I think in EDIC there is no negative marking as far as I remember. So everybody should be giving answer to all questions, whether you know or you do not know, you should give answer to it. So answer over is D. As to scrub typhus is always diagnosed as a PCR. Like here we most of the time we usually do scrub typhus PCR. So and the PCR based tests are now very popular, especially PCR based test, NGS based new generation sequencing, next generation sequencing, or NGS based tests. They become a confirmatory test, and especially the crux over here is the most sensitive and the early diagnostic test. IgM is also very sensitive for scrub typhus, but if you need to diagnose early, then we need to do a PCR based test. IgM comes positive after 7 days, after a week's time, 5 to 7 days later, IgM comes positive. But if you need to diagnose early, then we need to go for a PCR based testing. So the right answer is PCR based testing. Okay, so I think we'll do one more on the same. Let's see how many. Sorry, we'll do one more and then we'll stop. Okay. A patient with suspected scrub typhus has a negative IgM ELISA on day 3 of illness. What is the most appropriate next step in confirming the diagnosis? Repeat IgM ELISA after 7 days. Perform well Felix test immediately. Initiate empiric steroid and monitor. Start chloramphenicol and avoid diagnostics. Discontinue suspicion and evaluate for malaria. Okay. So what is the right answer? Yes, so Dr. Reed, yes, Dr. Saifan, so we'll have one more session probably. We'll tell the organizers to arrange for one more session. So I think this is the last question that we will be taking over here, and after that we will wind up for today because this is already exceeding 1 hour. So 1 hour was the stipulated period of time has been provided. But I just intended to keep it a little bit of more relevant kind of questions because this kind of questions probably will be expecting in the EDIC kind of exams, European exams. You will be expecting more question, a lot of questions on immunological diseases because they are less taught, they are less discussed, but they are extremely important. If you do not know those kind of things, you will not be able to crack, and that will determine whether somebody who passes, somebody who fails. So somebody who doesn't passes and somebody who doesn't pass. So if you know it, you will be able to do it, and that becomes a determining factor. Okay, the answer over here is again, as both of you have said, it's right. So we should do a repeat IgM. So as this question said that we did a IgM ELISA within 5 days of the disease onset. So IgM is expected to come negative. So we should always do IgM ELISA after 7 days. So we should do, as we have discussed in the last question, that we should do a PCR-based testing for the early diagnosis. Here, the PCR-based testing was not an option over here. So the best option that we have is the IgM ELISA after 7 days. Okay, so we'll wind up today. Dr. Fatima ji, is that okay? We might have another session next week or next to next week. So we'll.
Yes, sir. Sure. We can wrap up. Thank you, all the aspirants. Thank you, sir.
Thank you. Please leave feedback for this class and then feedback to the.
Sure, sir.